All right. So some of you have probably already had this class before, maybe a year or 2 years ago, something like that. Tim Vanderbilt was he was the one that taught the class before. So he recently retired and I've taken over for him. My name is Amanda Johansson. I'm a paramedic and a nurse. Little background on me is I started EMS first, and then I went through nursing school while I was flying with Airback. So I've been doing this for a little while. But again, most of my background is with EMS. So, all right. So what we're going to talk about in this class is what strokes are. This is just a refresher. It's just most of the information you guys probably will know. So what strokes are, the types of different strokes, EMS assessment, what we want you guys to do while you're out in the field, what we want you to do while you're doing your transport decisions, pre-hospital guidelines that are based off of Arkansas Department of Health, as well as the American Stroke Association and American Heart Association, what they want. The impact of strokes on how it impacts your community, us as a whole, us as a nation, and then some of the little bit of touch on the telemedicine that we do as far as with the IDHI stroke program out of UAMS. So before we get into this, I like to be a little bit interactive. I will ask questions. I hope people are responding. For those of you that are online, I can see your chat. So hopefully I can answer your questions over there. Just type in there that you can still hear me, since now it says no volume.
That was back at 9.
Okay.
Oh, wait, that was at 9:56.
He says, okay.
Who is it? Mike.
Facing.
Mike, can you hear us?
All right.
Okay.
There we go. Okay. So what is a stroke? Sudden death of brain cells, lack of oxygen, the ischemia within 1 hour, and then the edema. The edema is usually what causes the death ultimately, the lack of oxygen, and then the edema is what usually results in the death of the individual itself because of herniation. Ischemic strokes, 87% of the strokes that we have are ischemic strokes. You can either have an embolotic or a thrombotic stroke. 24% embolotic, 61% is thrombolytic. It is on the screen. The answer is up there, but I'm going to ask you, what is the difference between the two? It's still a clot either way, right?
Mm-hmm.
So one is where the clot is formed in the actual vessel itself, usually by plaque. And the other one is because the plaque or the clot itself was formed somewhere else in the body, and then it travels to the brain. You can also think of those as maybe your DVTs that started somewhere else, and then they moved. They go to 3 places, right? They either go to your lungs, they go to your heart, and they go to your head. Okay. All right, so the penumbra, this is ischemic penumbra. This is viable tissue that is formed around that area of the vessel that's being blocked off. Okay, this tissue is reperfusible if we can get them there in time. So it's not dead yet, but it is dying. Hemorrhagic strokes account for the other 13% of the strokes that we have. So these are your subarachnoids or your intracerebral bleeds. As you can see on the screen, intracerebral bleeds comprise of about 10%, and the subarachnoids are about 3%. Where do we see most of our subarachnoid bleeds? Or when do we?
Like falls.
Falls, trauma. All right. You can also have your intracerebral bleeds as well from some of those, but it's more likely you're going to have your subarachnoid hemorrhages. Some of this also is because of these go with small aneurysms that are misdiagnosed or not diagnosed. A lot of the time it's because people don't know that they have them. Sometimes it's hereditary. Sometimes it is a thing that they're born with, you know, that some of your pediatric strokes, sometimes they don't know because they were born with a small little aneurysm and they didn't know it. All right, so subarachnoids, some of the signs and symptoms: intolerance to light, neck stiffness and pain, and sudden onset of a severe headache, right? That thunderclap headache, can't stand the light. What does that sound like?
Well, also kind of sounds like a migraine.
Migraine. Okay, so just because they have a history of migraines doesn't mean that it can't be something else, right? Intracerebral hemorrhage, headache, nausea, vomiting, decreased loss of consciousness. Again, that one's kind of the one that we always learn when we're in EMS, right? That they're gonna have profuse vomiting. When I say profuse, these patients legitimately, they will have projectile vomiting, all right? It'll hit the back of the doors in the ambulance. And then once it's progressed down to the decrease of loss of consciousness, you're gonna have to worry about airway management and getting these patients to a appropriate facility. All right, hemorrhagic strokes, still responsible for 30% of the stroke deaths that we have. Intracerebral, most commonly from hypertension or uncontrolled or undiagnosed. And then your subarachnoids, these are trauma related. These are our falls, aneurysm ruptures, drug abuse. What do we need to worry about when we have drug abuse and alcoholics? Besides the big fall.
Well, they're already gonna be altered a little bit, so.
They're gonna be altered a little bit. What about our alcoholics?
It's
Things of blood, they bleed more, right? So it's harder to stop their bleeding. Drug abuse, usually their veins are fragile, especially if they're IV users, okay? So we might have a difficult time getting some IV started, or just in the fact that their veins, the walls of the veins, right? The tunica is gonna be very fragile, or it can be very stiff. So these patients already have hypertension, and now we need to worry about blood pressure control, okay? Also, drug abuse, big one there is gonna be cocaine, right? What does our cocaine users do? They're always hypertensive, right? Super hypertensive. They're usually tachycardic along with our methamphetamine users, because tachycardia increased cardiac output. Therefore, we have what? Elevated blood pressure, okay? So blood pressure management is going to be big on these people so that we can help keep the bleeding down. All right, left versus right hemisphere. So the left side of our brain, this is where all of our cognitive type thinking is, all right? This is our math. This is our ability to understand and process language. Our analytical, this is our logic. And then on the right side of the brain, this is creativity, imagination, right? So I like to think of right-sided brain people. Those are our arty-farty, right, people. And then the left side of the people are our analytical, our math people, things like that. Okay, so left side of the brain, if it's affecting that, it's usually going to affect your ability, your cognitive things. Right side of the brain, it's more of an emotional, that type of stuff. All right, left hemisphere itself. All right, so when we have a left-sided stroke, so the stroke's happening on the left side, what are we expecting on the right?
Deficits.
Deficits on the right. Well, what about their eyes? Eyes still gonna go to the right? Are we gonna have visual field on the right? Right, so the visual fields or their gaze is gonna go to the side that the stroke is on. Okay, so if the stroke is on the left side, you're gonna have deficits from the neck down will be on the right. And then from the neck up, typically it's specifically in the eyes, they're gonna be looking the direction of the injury, okay? Visual fields on this, they may not necessarily have a true gaze where it's stuck to one side or the other. And they may just have some blurry vision. The blurry vision is typically going to be in both eyes. It can just be in one, but typically it's going to be in both eyes. So again, they're going to have a left-sided gaze, so they won't be able to look to one side or the other if they have that. Otherwise, all the other deficits are going to be on the opposite side in which the stroke is happening. So also again, behavioral changes, because that's our cognitive area, right? Think of our personalities on the right. Okay. Right-sided hemisphere. These patients are again going to be looking towards the stroke, so they'll have a right-sided gaze. And then the rest of the deficits are usually on the lower, for your legs and arms are going to be on your left side. They may have some memory loss because of the area that it's affecting, right? It's the left side, the right side. Yeah, right side. All right, cerebellum. So cerebellum strokes, balance and coordination, ataxia, the finger, nose, heel, knee, shin, slide thing that's up there. That's what nurses will do during the NIH exam that they get done here. We don't ask you guys to do it out in the field mainly because we're conserving time, but you can throw it in there, and we'll talk about it here in a few minutes when we get to some of the stuff I want you to do out in the fields. But you can throw it in there because if we're trying to determine if it's a large vessel occlusion or LVO, you'll hear me refer to LVO a lot. So that stands for large vessel occlusion, if you didn't know. So these patients, balance and coordination, they might have sudden need to stand up and they need to walk by holding on to something, or you just notice that they're kind of leaning to one side, or maybe they're walking down a hallway and they're just using the wall with their shoulder to kind of stay upright. Okay. Stumbly, may look drunk.
The main ones I've seen like that, they can actually, with the exception of one of them, I've seen like that can actually, they can tell you what's going on. Then maybe they'll tell you, they may have just stood up and just walked back in their chair because then when they stood up, that's when everything broke loose. And when they sit down, they can talk to you, they can do.
Right.
One can do everything except for stand to balance. And because it was based on like that.
Right.
And it's
So-
an oddity.
And that's true. So the because of where it is, where the stroke's being happening, it's not necessarily affecting your cognitive area, right? They may be negative on your Cincinnati's or your BFAST, right? They may be negative on that because, well, not BFAST, but if you're only doing a Cincinnati, you're maybe negative because balance isn't on the Cincinnati, right? But that's why we want to do BFAST, and we'll get into that a little bit more too. But yes. So these get missed because some people don't do a true BFAST exam. Okay. All right, and then we have brainstem strokes. These get misdiagnosed all the time. All the time. And most of the time, these patients, by the time they find it, they have very poor outcomes. All right, these end up being sometimes your vegetables, right? In the vegetable garden. Some of these end up being dead, essentially. But most of the time, these get misdiagnosed for three reasons. One, or the big ones right there in red, nausea, vomiting, and vertigo. How many of our little old ladies do we pick up that says, I just don't feel good?
Yeah.
I'm dizzy, right? You take them up to the ER, doc sees them, they don't get a CT. We're gonna give you some meclizine, we'll send you home, you got vertigo. 3-4 days later, go pick up the same lady, and she's completely flaccid in the bed, or she's your next code that you end up working. Okay. Another big one right there is the tinnitus. They're ringing in the ears. Those are the three big ones that typically that's what they'll get diagnosed with. They'll get diagnosed with some vertigo or some tinnitus, sent home on some anti-dizzy medication, and then send them on home. Sometimes by the time it's progressed, they're going to have some dysarthria, the speech, and then the dysphagia of the swallowing. So they might be a little drooly. They can't control their airway because they can't control their secretions. They're having difficulty with their speech, saying the wrong words, or they just can't get the word at all. Okay. And then the just generalized dense weakness. This is usually pretty progressive at this point. Questions? All right, TIAs. TIAs, how many of us used to be told these are just mini strokes? Don't worry about it. All right. So technically, if you want to get into the actual definition of a TIA, in theory, they are strokes. Okay, so they, it is caused because some sort of disruption of blood flow to that area created the symptoms. But usually that clot moves on or it disposed of itself, so it wasn't big enough for it to stay around and do anything with. So that's why you usually see a rapid resolution within 30 minutes, 15, 30 minutes, right? Patients with TIAs, they are more likely to have strokes afterwards. 1 in 3 people end up having a stroke. And typically, if they're going to have one, it's going to happen within the next 48 hours. Standard of care for TIAs when they come into the hospital, they should be getting CTs and they should be getting admitted. Okay, they should be getting admitted to have a full workup. They should get the MRI the next morning, something like that. That is the standard, should be the standard of care. It is the newer standard of care. So they should have a full observation. And because of that, 1 in 3 people are going to go on to have the stroke, and it's probably going to happen in the next 48 hours. Okay. Don't know all these patients as much as they don't want to. We need to talk them into going and at least getting that CT.
Can you go back 1 slide for just a second? Thank you. I got it.
Anything else? You still good?
No, I'm good.
Keep going.
Look, I got it.
Any questions in Zoom land so far?
I've been watching the chatting volume is good. All right. Okay, so TIAs, make sure you're transporting those patients. Don't let them talk you out of it. If they do talk you out of it, even though you've sat there for 10, 15 minutes, make sure to document, save yourself that you tried multiple times and they completely refused. Okay.
I don't know if I've ever had anyone that had some talking going. Usually if you explain to them that that's actually a marker for strokes.
Mhm.
And then usually somebody's gonna have a full on stroke, it's within 24 to 48 hours after that, and that's why the doctors like to have them do the 24 observation, so it's right there, and something happens, so it's not there. Usually they will let you transport.
Most of the time, like you said, by the time you bring in the word of death, you're going to die. A lot of times they'll change their mind, they'll go ahead and go, okay? Stroke mimics. First one up there is the big one, it's why we want you to check a blood sugar, right? Hypo or hyperglycemic. What blood sugar range? Everybody's protocols are a little bit different, but nationally, what do we kind of look for as far as what we need to treat?
Below 60.
Below 60. All right, and then what about if they're hyperglycemic? What kind of symptoms might they have if they're hyperglycemic that you would think would be like a stroke?
Fruity over, or like a stroke.
See, these are stroke mimics, things that we would think, oh, this could be a stroke, but really it was a sugar problem.
Like confusion.
Confusion. Okay,
Altered level of consciousness.
altered level of consciousness,
Staggering.
staggering. Okay, very good. All right, so metabolic imbalances. Metabolic imbalances, what are we thinking there?
Like sodium, or is it
Sodium?
about like
Potassium.
Potassium. Those are my 2 big ones. What do your patients present like when they have high, they're hyperkalemic, right? They have high potassium, or if their sodium's out of whack.
like irregular rhythms with the potassium, or confusion or seizures with low sodium?
Confusion, altered mental status, some seizures with the sodium, right? Potassium, you could have some EKG changes, you can. I'm thinking, how do they present physically?
Bizarre behavior.
Bizarre behavior. Or if it's super high, like in the 7s, because they're critical and they're gonna die if something doesn't happen, right? They're very flaccid. They're not there. There's like nobody's home, okay? And that also kind of goes the other way too with the hypokalemic as well. All right, seizures. Why do we think that's a stroke mimic?
What can result from a stroke? Is that, or just
Yeah,
A seizure can cause a stroke, your stroke can actually be, anyway, because the patient sees material, it becomes their ICP bill.
I couldn't hear the last part. Say the last.
ICP goes up to admission. Seizure is.
So they could have an anoxic brain injury from that, you know, right? Because of the lack of oxygen when But what about a seizure itself mimics a stroke? Not that it could cause a stroke, but what kind of things?
Like the postictal.
Like
There we go.
postictal
Postictal
phase.
phase, right? So a lot of these times, these patients, if they have a history of seizures, or even if they don't, they don't, some of them can tell you, I had to have had a seizure because, I could feel it coming on, right? So how many of them has told you I felt like I could feel it coming, I sat down, right? For those that don't, the changes in behavioral, right? When they wake up, some of these patients are postictal, they are very confused, they don't understand what's going on, or they're combative. Anybody have a postictal that's combative? I did one time. It was an aircraft and it was not fun. It was not fun at all. He was a big guy. He was probably about 270 pounds and 6'2", and he come out of that seizure and was a swinging. Anyway, he went down quickly, so.
Out of the helicopter or chemically?
Did you eat them?
Both. We had an emergency landing in a field and we intubated him, took him.
Wow.
So it happens, right? They have a very big change of behavior that's not known for them. So that would be, but if they don't have a history of seizures, you don't know.
Well,
Yeah.
if they
Right.
have a history of seizures, some of those you'll occasionally see even younger people who are on antidepressants, where they can actually cause them.
True. Yep. They also change their sodium, right? Our schizophrenic patients, and their medications can make them just drink tons of water, right? And then we get our sodium all mixed up. So some of these are, if they don't have histories, we gotta be our little detective things, and we'll talk more about that too. But you're absolutely right.
Sepsis can also mimic stroke if you got a patient that's treated with septic. It's the same
Mhm.
symptoms that you would see with stroke, where you just really roll and alcohol stuff.
Yep.
So.
We got infections down there on the
What
bottom.
is
We're gonna get to
FSBS under hypoglycemia?
fast, that's finger stick blood sugar.
Okay.
All right, migraines, we kind of already popped on that one earlier, right?
So I have a question about that,
Yep.
going back to finger stick blood sugar.
Okay,
Should a preference over, because we usually use the blood out of our needle stick. So is there controversy over a needle stick versus a finger stick?
there is technically documentation out there that shows that when you do a finger stick blood sugar, where are you taking it from? Capillary, right?
Mhm.
So what happens during that capillary part that is not happening in the venous part?
Metabolism?
There's some metabolism, but there's an exchange, right? So we have, in the capillary level, we have oxygenated and unoxygenated, right? So that's
Mhm.
already metabolized blood typically, or it's being metabolized. So they can give you kind of a little bit different reading. Now, in my experience, personal experience, professional opinion, it doesn't matter that much. The difference between the two is pretty minute. Now, it may be like 1 or 2 points or something like that, where one blood sugar might give you 64, and then the other one that you take venously might be 70.
Mhm.
So you can see, well, it's like, well, one of those I might treat, and the other one I'd be like, maybe we can have to treat my patient instead of the monitor or something like that. Make sense?
Mhm.
So there is a little bit of discrepancy in it, but as far as what we want you to do, whatever you're comfortable with. How's that sound?
Okay.
My political answer.
So
Whatever
maybe if like, of course, like if it's a stroke, like a legit stroke, we get our IV started, we do our sugar. And maybe en route, do a secondary and do a finger stick
can do that.
to see if it's changed or
So-
something different.
So when you're saying you get them from the IV,
Yeah.
because we have the safety cath, right, and then we take our pen and we push that little foam piece and it puts one little
Yeah.
drop out. Done it for years.
Mhm.
Totally okay with that. But as your initial, but if something is making you think, hey, maybe it's off, whatever, go ahead and stick your finger.
Well, and with your
Not a big
ones,
deal.
especially when seizure is present, you also have the fact of how long did they seize for as a sugar in the tank. Because what that sugar is, needs to leave continuous drop.
Correct. Yeah, because during the seizure, you know, they're having a whole lot of metabolizing going on, right? All those muscles are doing everything. So, contracting, so that is gonna use up more sugar. But either one, political answer, whatever you're comfortable with. Here in the hospital, if they came in POV, right? Are you guys gonna use your IV one, or are you gonna get a finger stick?
Finger stick.
Finger stick. It's whatever you guys feel comfortable doing is the best answer for that one. I can't say no, can't say yes.
If I already
Yeah.
got poking with an IV, why do I need to filter finger? Unless I gotta recheck it.
Yeah.
Start another review.
Start another IV.
Start another one. All right, migraines, we've already touched on that one. Let's go back. We're gonna go to syncope. Syncope, why is it a stroke mimic? Well, most of the time we think syncope is cardiac related, right? But syncope also can be near syncope. Okay, we have that dizzy feeling. I feel like I'm gonna pass out. Well, let's go ahead and do what?
Oh,
12 lead, but we're gonna do what?
Last exam.
The blood sugar.
Feedback.
Blood sugar. There we go. Right?
Do it
Feel
all.
dizzy. I don't feel good. Just feel real weak. Well, why wouldn't we check their blood sugar? Make sure it's not a sugar problem. Even if they don't have a history, they may be a new one. Okay, so they all kind of go hand in hand. Parkinson's disease, what's the big one there? What happens as they're to these Parkinson's disease patients that we would think maybe could look like a stroke? Remember, these are not because they're having a stroke. I'm just saying what would, if you think
Deficits?
Parkinson's.
I can't remember what it's called, but it's that stage where they basically are nothing, like they.
Yeah, once
The
they're
weakness.
the weakness, the tremors, okay? It's the tremors that you're thinking. A lot of times it's in both hands, whatever, right? And when we're having a stroke, we think usually more it's unilateral. But as their disease progresses, they're gonna have some stumbling. They're not gonna be able, they'll have some balance problems, okay? And sometimes Parkinson's disease, most of the time, these patients are already gonna know that they have a history, right? That they've been diagnosed with this. But what if it's early on in their part and they didn't know? And they're just now having these tremors and they're having some difficulty walking. Okay. Conversion disorders, anybody know what a conversion disorder is? It's the political term for our crazy people. All right, so this is anxiety, this is our mental health people,
Oh, I fit in this category.
all right?
So you have a conversion disorder.
It is technically the nice word of grouping them all together is called a conversion disorder. Definition for conversion disorders are basically where you're having a psychological event kind of thing that is causing neurological deficits. Okay, but there is no actual neurological cause for the deficit. That makes sense? So how many of us have heard that these severe anxiety, I use the anxiety one because it's the one you're gonna see the most often. So anxiety patients that are so severe of anxiety that they have the arm numbness, tingling, you may have some paralysis, and it is actually legit. You try to pick their arm up and it falls flaccid. But it's just the anxiety that's actually causing this. So it's not an actual clot neurological problem. It is a psychological problem causing a neurological effect. Something big.
It's a radio.
Okay, all right. Makes sense? All right, so your anxiety patients, they can present as stroke mimics as well. Tumors, if they have a known tumor, don't have no tumor, but they can cause the seizures, right? Toxin exposures. We touched on this earlier with the cocaine patients, which are real hypertensive, they may be nauseated. What other toxins? This probably don't have it too much up here, but I talk about it down in the south where all the farmers are all the time. Organophosphate, our purple box people, right? Okay, so organophosphate poisoning, there is some data out there, some research that has shown that there has been multiple people that have come in with organophosphate poisoning that were actually thought to be a stroke because of their symptoms. And then it turned out they were actually diagnosed with organophosphate poisoning. Bell's palsy, what's the difference between Bell's palsy and an actual stroke?
Usually they're gonna be diagnosed with Bell's palsy, right?
And it
Well,
goes.
they're gonna be diagnosed with a stroke too.
It is different than
Well, it's just the facial Usually
Hey.
it's Bell's palsy.
right? Bell's palsy is usually just in your face.
Yeah.
One other big thing is it hurts. Bell's palsy is painful. They'll have jaw pain, they'll have ear pain. Okay, with Bell's palsy, it is painful. It's usually the big telltale on Bell's palsy or whether or not it's a stroke. Now, if you're out in the field and you have a patient and all they're showing us some facial weakness or, completely facial droop or whatever, just because they say it hurts, please don't be like, oh, you got Bell's palsy.
You'll be
You'll be fine, right? Go ahead and bring them to the hospital, call your code stroke and make sure that it is. But that is one of the biggest differences is Bell's palsy is painful as opposed to not being painful when it's a stroke. Dementia patients, grandma, grandpa at the nursing homes, altered mental status, we think they're having a stroke. How do you know? What is their normal, right? And my screen is going, connection is lost. Trying again.
It'll come back.
Okay, so dementia patients, what is normal for these patients? Please make sure that you're asking when you're out in the field. Talk to the CNAs. Usually the nurses don't always know what's going on in the nursing homes. Infections, we kind of talked about these already. You brought up sepsis, right? Our septic patients, they're having an altered mental status. Most of the time we know though, when we're having our sepsis patients, even if they're not febrile at the time, they instead of being hyperthermic with a fever, they might be hypothermic, right? Where they don't have a fever. But most of the time our sepsis patients are what? That our stroke patients are not. It's a vital sign that I'm looking for.
Oh, it's a hypertensive.
Hypotensive. Okay, most of our stroke patients are going to be hypertensive. Not always, but most of the time they are. Not too many stroke patients are going to be hypotensive. Most of them are going to be either normo or hyper. All right, insulin pumps. This was Tim's big one. Tim liked to stay on this for a minute. We're not going to stay on it as long as Tim does. Mainly because he was very passionate about it. All right. He wore one and, so he was very passionate about it. I don't wear one. I do have family that do. So insulin pumps, leave them alone. It's the gist of it, right? I like to contribute this back to our heart attack patients, our chest pain patients. If we give them a sublingual nitro, how much nitro do we just give them? 0.4 milligrams. All right. What happens if I give that nitro and now their blood pressure is crap? It's in the dirt. What do I need to do? Did I did anything wrong? No, they were having chest pain, following my protocol, right? Maybe it's inferior. So now all of a sudden they're hypotensive.
You killed them.
We're going to give them fluids, right? We're going to stand them on their head. We're going to give them fluids and be like, oh crap, just wait a little bit longer. Okay. So for insulin pump, same thing. We can't get the nitro back that we gave our chest pain patient. All we can do is treat it. Same thing with your insulin. It's already in there. Don't worry about the pump. All you can do is treat your patient. Okay. Don't worry about the machine. Most of the time they're locked, and you're more likely to accidentally give them a new dose than you are to unlock it and stop it. Don't cut the tubing. They only get so many tubings and connections and all of that per month per their insurance. As soon as you cut it, now they got to use another one and they got to pay for a new one, and the insurance isn't going to pay to recover it.
A lot of the newer pumps are set to shut off and once it gets down to a certain point.
Yes.
And stop it.
Correct, which is why once it's been given, it's not going to give it anymore, right? All we're going to do is treat it. Some people are like, well, what if I give them, I know you guys probably don't use D50 up anymore. Most people always switch over to D10, right? So, but back in the old days when we used D50, I'm like, give them a whole amp. Now we gave their sugars up to like 260. What are we thinking? Well, now the pumps can be giving them more insulin, right? It won't. It knows that it just delivered. It knows that it went too low and it's being treated. It's not going to give them more insulin. Okay. Questions on that one? Nope. Got to pee?
No.
Oh,
It better be.
better. Okay. All right. So bottom line is don't touch them. Just treat your patient. Don't treat your monitor. All right. Cincinnati stroke exam, right? Well, some of us probably were in EMS when this was what we were first taught, right? Your Cincinnati score.
Still actually using parking places.
And then we went to, the BFAST. Well, BFAST is because that's what the Arkansas Department of Health says we're gonna use. It also is backed by the American Stroke Association as well as the American Heart Association, that they say, hey, BFAST is a little bit better than Cincinnati. But Cincinnati was by itself 72% accurate in determining if it was a stroke. Just off of three things: facial droop, arm drift, and speech. Then you had LA and you had Miami and you had a few other people that decided they were gonna make up their own. And none of those really worked, because usually the first question made somebody go away, right? Male or female. It was almost always on all of everybody else's, male or female. And if they were a female, you were chucked out. You're not having a stroke because you're a female. Actually, women usually have bigger strokes. They may not have as many as men do, because women actually go to the doctor and they do what they're supposed to do. Sorry, guys that are in the virtual side over there, but there's nobody on your team to back you in the ring. So, but they usually will have bigger strokes as opposed to men who might have multiple strokes throughout their life. They're just not as severe. Does that make sense? So BFAST is what we end up switching to. There we go, BFAST. So BFAST is just a Cincinnati score with a couple of two things on there, right? So Cincinnati was face, arms, and speech. BFAST is BE. We added the BE on there. T for time, it was kind of always with Cincinnati, but it is actually on there. This is preferred again by the American Heart Association as well as the Stroke Association and the Arkansas Department of Health. B stands for sudden loss of balance, changes in vision in one or both eyes, facial droop or uneven smile, arm numbness, weakness, slurred speech. How many of us were taught, tell them you can't teach an old dog new tricks? I can barely say it, like right there, I had to think about it. I can barely say that just standing here sober, nothing wrong with me, right? So sometimes that might be hard for somebody. Or what if they have a lisp? I don't know if they have a lisp. Okay, something that they can say. It doesn't have to be that necessarily that phrase. Use simple words. When the nurses are doing their NIH score, there's a few words that we use like caterpillar, mama, tip top, 50-50. Those kind of words, just simple words that they can say and see if they can do it. Time. This is going to be the last known well time. We need to know it. It's going to change 3 or 4 times before you get to the hospital, but pinpoint as best that you can. And then when we're teaching this out to the lay person, it's going to be that when did this happen, and it's time for them to call 911. This is just a picture representation of the BFAST. And then this is an excerpt from the Arkansas Department of Health. They specifically said this: they want BFAST assessment tool as an expansion of the Cincinnati. It's being taught to the public and the healthcare providers. Since it is an accurate assessment tool, it is now recognized by the Arkansas Department of Health Emergency Division as the assessment tool to notify emergency departments. So, per the state, the person that holds your license, they said use BFAST, so use it. Okay. Also, call the hospitals identifying if it's a code stroke. VAN tool. Anybody familiar with the VAN tool? Nobody? All right, so you remember how I said I was going to revert to that thing where I said LVO, large vessel occlusion. All right, this is a tool that you can use when you're out in the field to determine where, kind of where that or what vessel is being occluded. Okay, the VAN tool adds 3 extra things: vision, aphasia, and neglect. If they fail one of these 3, it's more likely to be an LVO. Doesn't have to be all 3. Doesn't have to be 2 out of 3. Just has to be 1. And then it's more likely to be an LVO. All right. So vision, if they have a right-sided gaze or a left-sided gaze. This is not vision where they're having an impairment or they're having blurry vision. It is fixated. You move to the other side of the cot and they can't do anything to look at you except for maybe turn around like an exorcism. Okay. They have to actually be able to move their eyes. If they cannot, that is considered a gaze. Okay. Aphasia, naming difficulties, point to your watch. What is this? And they can't say what your watch is. Or you point to your glasses, what are these? And they can't say what, little things. I'm not asking you to do difficult things or anything like that. Don't point at your cardiac monitor and say, what is this? Okay, they might not know. They'd be like, I don't know, some sort of machine or something, right? So naming difficulties, but these need to be things that are very easily to be able to be named. And then neglect, ignoring the left side of their body. You pick up their arm and you say, whose arm is this? And they don't know. Like, I don't know this arm. They can't feel that you're touching it. They don't know that you're touching it. They don't know that you picked up your arm. This is their neglect to their own body.
So
Okay?
why just the left and not the right?
You're the first person to ask me that question. I knew it was gonna happen and I had the answer at one point, but I don't remember what it is right now.
Okay.
So I will find out and I will let you know. Unless you know.
No, but if it's the left side over there, they're still gonna be able to have their speech cortex, so they're gonna be able to get somebody to talk to. Is that a deal? It's already which side in that respect?
Some, but left side also affects language, right?
The brain left side does. Because that would be the right side of the body.
Right,
If it's the left side of the body, that's the right side.
correct.
So your speech cortex should still be there. If it's the left side of the body, because it should be the right side of the throat.
Okay. Well, we will look it up and we will find out what the actual answer is. All right, pre-hospital guidelines. This is what we want you to do while you're out in the field. These all should be emergency dispatch to include your interfacility transfer of a stroke. All right, so if you're, yes, ma'am.
I'm just gonna tell you the answer.
Yes, please get me the answer.
So neglect can happen to either side of the body, but the left is more common.
Okay, there's our answer. Thank you.
Thank you. Thank you, Google.
All right, so pre-hospital guidelines, these all need to be dispatched as a priority call. These need to be 911 and you run hot on these to include your interfacility transfers. If the hospital calls you and says, hey, we have a stroke, it's gotta go to, I don't know, let's see, let's send you guys to Missouri. Go ahead and send you to St. Louis on that long transfer, okay? So,
Could we not stop at Springfield?
nope,
Come
nope, you're
on.
going all the way, going all the way. So, for even those, they need to be 911, okay? You need to have an emergency. Think of this as your STEMIs, just like that. They need to go. We need to get them out of there.
The closest facility, which is not be St. Louis.
Wherever the doctor, whoever accepted.
Well,
Okay?
it's not far away,
So-
still has no ICU bed, okay? On the right
None.
side.
We're back in the COVID days and you're going.
That's when you walk in and explain to the doctor. Now, doc, you realize that when they're like this, it's gonna make their ICP go up after a certain point, right?
Yeah, they probably do. And then they'll tell you, why don't you go ahead and put a shunt in while you're going? All right, so EMS should load and go on these patients. You need 10 minutes or less of your scene times. I know that it's hard sometimes, right? The hardest part, the longest part is usually getting these patients out of the house. Okay, well, let me grab this, let me find this, right? Or I need to do this. Well, what about my dogs? Okay, so we need to just grab these patients and put them in the truck, okay? And we can do our Cincinnati, our BFAST, I'm sorry, our BFAST exams while we're in the back of the truck. We can do a band score, but we don't want to delay time doing a band score. All right, so regardless of the last known well time, preferably the stroke ready hospital, and even if it is an LVO, okay? Because that time is what we need to get them here for. Giving pre-hospital notification. We want you to call the ER on the radio, on phone, however you normally give your reports. Let them know, hey, we're 10 minutes out, 5 minutes out. Hey, we're pulling up right now, but we got a stroke, okay? And this is, this is what their failed deficit is on the BFAST exam. They failed this part or whatever, okay? Their sugar was this, or hey, I don't got time to give you a full report. This is a code stroke. We're coming in. We're gonna go straight to CT. I'll see you in like 30 seconds, okay? Whatever you have to do, but please at least notify them that it is a code stroke. take the patient straight to the CT. You should be working with your ERs with this. If this is not being done here, please work with them. But I'm pretty sure it is. Get them straight to CT. Don't stop at go and collect your $200. Okay. Drop your paperwork, drop your computer off at the nurse's station, say, here's his demographics. We're gonna go ahead and go to CT. They can put them in while you're going down it. Why do you want the CT so fast?
To see if,
Do what?
Time is brain.
Time is brain.
to see if they have a bleed.
There you go. We need to rule out the bleed so that we can see if this patient's even a candidate for the medication, okay? All right, do's and don'ts. As you can see, there's a whole lot of do's and not a whole lot of don'ts, and we still want you to do it in less than 10 minutes,
Okay.
okay? Assess and manage your patient, just like we do for everybody. We want you to do a BFAST exam. We want you to activate your code stroke to the ER. Get your last known well time. That's kind of on there twice because T and BFAST is time, right?
It's important, though.
Cardiac monitor. Why do we want you on the cardiac monitor for your stroke patients?
To rule out cardiac.
Yeah, you could be having an MI while you have a stroke.
Are you still wanting 12 leads? In these patients?
And for
Oh,
sure want a
yes.
4 lead unless you see, or 3 lead, whatever you want to call it, unless you do something. What?
Your syncope patients that can mimic stroke, so your 12 lead helps rule out it being cardiac versus being syncope episode versus something stroke.
Yeah. I'm looking for one specific thing. Anybody online want to chip in? You're probably not listening. You just got the phone going.
Is it in case that clot moves?
You're getting in the right direction.
Just in case they flatline.
What is the cardiac monitor going to tell us?
Ischemia.
Yeah. Kind of, not.
Blood
correct, but
pressure?
Yeah.
Yeah.
Wait, no, that's a.
Not everybody has fancy ones that the cardiac monitor does blood pressures too. You might have to take manuals still. What else?
We have a couple
Heart
of
rate.
rays still.
Heart rates,
Heart rhythm,
rhythm. What rhythm am I worried about?
asystole,
Not really, because I know what to do with that one. All right.
AFib.
Yes, AFib.
Oh, okay.
Why AFib?
This is the pro clots.
They continue to throw clots. We don't know if this is new. We don't know if they have a history.
Got it.
We got there. We don't know if they have a history of AFib. We don't know if this is new onset AFib. New onset AFib, is it happening because they have some sort of infection or is it whatever? But what else can AFib tell us on the monitor, especially if our patient can't talk? How do you treat it? What are these patients on?
Blood thinners.
Blood thinner.
Blood thinners. These patients are more than likely on blood thinners. So if our patient can't talk, I can use another tool to tell me, well, maybe they're on a blood thinner and now they can't get what?
They can't get the.
They can't get the medication, maybe. But that also can tell me, well, if this fool is up in here with some AFib, he's probably not taking his what? His medication, right? He's probably not taking his medication, which therefore means that he still can get the medicine. Okay, please put your patients on the cardiac monitor. It can give you a lot of information other than just saying, I put him on the cardiac monitor so I can bill for it. Okay, use it. It's a tool. It'll tell you a lot about your patients. Finger stick blood sugar. Do what?
I did not know that.
Did not know any of that. Well, so we got AFib. It throws clots, right? A lot of
Oh,
times
yeah.
that's what we're worried about. And then we have, most of the time, these patients that
Yeah.
are on AFib are gonna be on blood thinners, or they're gonna be on some sort of antiarrhythmic or beta blocker, something like that. And if they're in the rhythm, then we know that they're probably not taking their medicine. Okay. All right. Finger stick blood sugar or FSBS.
You're learning so much
I
today.
know.
Look, that is my job. If somebody learned at least one thing when I leave here, then my.
I've
job is done.
learned two.
I was paid appropriately. All right, treatment if needed. All right, so we treat this if it's needed, okay? Maintain oxygen saturation above 94%, according to the American Heart and American Stroke Associations. We don't put oxygen on people unless they are what? Below 94%. Dead.
Assistantly.
If they're dead, I don't know, the oxygen's really gonna help them.
It might.
Anyways.
It
Black
might.
tag.
Black tag.
I'm calling the corner. No, I'm just kidding. Okay, Establish an IV, we want two if possible, but one is sufficient, but we would prefer two. While you go ahead and start that IV, you can get your not finger stick blood sugar, and you can also pull blood if possible. You guys pull blood?
Yes.
Yes.
You put it
For
in a
now.
10 ml syringe and bring it in saying, here you go.
No,
So
we,
proud.
we tube it.
Okay, good. All right. Most of the time, people bring it in a 10 cc syringe, be like, hey, I got this 20 minutes ago. Here you go. And it usually goes in the trash because it's hemolyzed and we can't use it. But it was a good effort. Okay. All right. Maintain NPO. These patients need to be NPO. So what if this patient is a stroke patient? They have some left-sided weakness, but they're complaining of chest pain. Now I got two protocols. What am I supposed to give that chest pain patient? Aspirin. Well, it's stroke patient. He's got left side weakness. I gotta keep him NPO. What do I do? They're both parameters.
What's gonna kill him first?
Probably choking on that aspirin, right? Don't give them the aspirin. I know they're supposed to chew it anyways, you know, yada, yada. Don't give them the aspirin, but notify the ER and say, hey, they were also complaining of chest pain, do everything else, do a 12 lead, do all that other good stuff, right? But you're just gonna keep them NPO. Because what does the hospital have that you guys probably don't?
More hands.
Lab.
Yes, and one of those hands is going somewhere else, or at least one of those digits is. Right, they're gonna get supplemental, right? They're gonna get some rectal aspirin, okay? They can still get their aspirin, just not gonna go PO.
Aspirin? No, okay.
Y'all ain't giving some suppository aspirin? Come on now. You gotta meet your matrix.
Yeah, we like, we're not that.
I didn't
All right, so the answer to the question is
Don't give anything.
don't give them anything if they're having stroke-like symptoms, okay? Even if they complain of chest pain, but they can still technically get aspirin. That's not necessarily a no. But they're just gonna have to get it a different route,
And
okay?
it's the choking hazard.
Correct.
It's not about the blood.
No.
Okay, thank you.
What is aspirin? Is it blood thinner?
Absolutely.
Platelet.
It is not. Aspirin is a platelet inhibitor, right?
Yes.
So what does that mean? Does it thin the blood or does it
Just keeps the platelets in the
It
skin.
helps.
keeps from making the clot bigger? There you go. All right, elevated to the head of the bed, 15 to 30 degrees, as long as they're normotensive or hypotensive. Why do we want that? Even if they're hyper or normotensive, why do we want their head of the bed elevated?
So they don't choke.
If the
Okay.
head died of elevated.
Because you gave them that aspirin?
Yes.
Yeah.
It's like pressure,
Could
You
get
went-
messed up.
so
Yeah.
for like
The
because of the
diabetes.
pressure. Or
Yes, it is because of blood pressure. What about the blood pressure?
But then if they're hypotensive,
Normo or hyper? We want them up.
Because
You
it'll
want it
decrease
up.
their blood pressure or
Yeah.
help.
Yes.
You wanted the
It
blood
increases.
pressure.
We want we want
Yes.
therapeutic hypertension, okay? We want that because it's the only thing that's pushing blood past that clot to perfuse that area.
Mm. Wow.
Yeah, that's why you don't treat hypertension in a stroke.
Unless, all right,
Okay.
we're gonna touch on that because we're going there next.
Question.
Yes,
You've got your patient that is complaining of chest pain, doing your 12 lead, suspected stroke, morphine.
With
Cause
the
it's gonna
platelet.
lower blood pressure. Would a fentanyl be?
All right. so I cannot tell you guys how to run your protocols, okay? This is not my job. However, if these patients are in pain, what are we gonna see?
higher blood pressure.
Higher blood pressures, elevated heart rate, tachypnea maybe, right? So if we treat the pain, what's gonna happen?
You're gonna lower the blood
We're
pressure.
gonna make our patients more comfortable and our blood pressure is gonna go down. Now, I cannot say for you guys to use or put that in your protocols. I'm not here, I'm not a physician, I'm not allowed to say that. But
However,
comma. Have I ran a lot of places where that is in my protocols to treat the pain first before I treat the blood pressure? Yes, because you can still have your hypertensive threshold that you need to perfuse, right? But I'm making my patients more comfortable and I'm treating that critically high blood pressure at the same time. Okay, without giving them 3 2-3 dosages of labetalol, and now they've all finally caught up, and now it's blood pressure's in the tank, or it doesn't work at all, right? And we're still not getting anywhere. So I can't tell you what to put in your protocols. I can't tell you how to work your protocols, but we all have a protocol that says pain. We all have a stroke protocol. Nothing says you only can use one, right? We can kind of marry things together. Anyways, so morphine is not necessarily contraindicated as far as a stroke patient, but I can't tell you what to use
Okay.
legally. Does that make sense?
Mhm.
Okay. Especially because I'm being recorded on this.
Well, it's just a consideration that, you know, for us in the truck, I mean, it's gonna be clinical judgment anyway,
Right.
but a suggestion from somebody that's had experience with it, and of course is teaching it, goes a long way.
Yes, so just know the physiology of your patients and what you're gonna see, right? We all went to school, we all went. This one over here, looking at the wall. Did you get yours out of a Cracker Jack box?
I did.
You did not, because I got the same education.
So did she.
It's all right, I found mine there first too, and then I just developed on it, okay? All right, so, but for real, we know the body, we know what happens to the body when it's in pain, right? And prolonged in pain. These things are gonna happen, we're gonna see changes in our vital signs and stuff like that, and there's ways that we can think outside of the box, we don't have to be in one little box. All right, now we're gonna go over the don'ts. You can see that there's only 2 up there, and it says don't treat hypertension. Okay, we still need to treat the hypertension. I'm gonna specify that, we're gonna treat it. Whether it's however we decide to do that, okay? We only want to treat hypertension if it's above 220 systolically, okay? The reason for this is because we still need that therapeutic hypertension, all right? Our neurologist for our program specifically said, hey, make sure when you're teaching these EMS folks, they know that they can still treat a blood pressure if it's over systolic 220, okay? But if it's not over, just leave it alone. All right. And think about it
Labetalol.
and other things, but if it's over 220, we need to go ahead and start treating his blood pressure and get him down a little bit into like 185, 190, okay? It's still a little hypertensive, but we're perfusing. All right, yes, labetalol is probably one. It's the most common that EMS carries if you carry it, but the state doesn't require EMS to carry it, so.
Is Baxter carrying labetalol? Okay.
Yeah, so some do, some don't. I've been to places where one of the ground services I taught at not long ago, I used to work for them, they carry carding. Okay, they carry labetalol, they carry hydralazine, their medical director is very, hey, use this stuff. But not everybody's like that, right? Some EMS, they don't even carry labetalol. You get what's minimum of the state for us to require, and I want you to work with that. You know, so it is what it is. It's the job that we do. We just have to think outside the box of what we got. Okay. Don't waste time on the scene. We want you to be less than 10 minutes, like I said, but please do all of those other things that we talked about in less than 10 minutes. Okay. Any questions about the blood pressure management stuff? Anybody online? No. Okay. All right. Transport considerations. Obtain a family contact, bring a witness if possible. We need a witness. Assess rapidly. And transport emergent to the nearest stroke-ready hospital. Stroke-ready hospital. What does that mean?
That has the
AR safe.
AR saves.
AR saves. I can't say that no more.
What?
I'm not allowed to say it anymore.
So what do you say?
IDHI stroke program.
That's too many words.
That's too complicated. They need to go back to the other. It's so much easier to say.
So
It's Arkansas.
it's Arkansas. All right, you need to take them somewhere that can do what?
Stroke.
What was it?
Stroke.
IDHK what?
Yeah. IDHK. I don't even know what that stands for.
I don't
IDHI.
know if I know.
IDHI.
IDHI.
I'd high.
I high.
Exactly.
All right, so you need to take them somewhere that is part of our program. So that, because, what can those facilities do?
Blockbuster.
Yes,
CT.
CT. They can do a CT, they can rule out a bleed, and they can give a medication, right? After that, more likely they've got to go somewhere else. But they can at least get the initial standard of care that they need. if you were to bypass a stroke-ready hospital that is specifically in our program, you can potentially lose a standard of care lawsuit.
But what if they're so adamant and not going to the facility?
Your documentation better be on point. However, you are the medical care provider of this patient, and if you have anything that says that they may be cognitively not capable of making their own decisions, what can you do legally?
Make the decision. for
Take them
them.
where they need to go. Make a decision for them. Okay, so documentation is your friend. I know we hate to document. It's one of the least things in my job that I have to, I despise it. I have since I started in the medical field. I'm sure I'm not the only one, but I've learned to be able to document, to be able to do what needs to be done. Okay, and keep yourself and protect your license, because ultimately you're the only one that can do that. All right, so be careful with that. If they are adamant about taking them somewhere that is away from where you need to go, make sure your documentation is on point. But you can also use the little thing, some providers, services have an extra form that says, if you choose to go to this facility, that's fine, you sign this, but if you die on the way because we didn't go somewhere closer, it's on you. All right,
We have that.
see,
Yeah.
make sure that's getting signed, okay? But we do want you to take them to as close as facility as possible.
I like how she put that, if you die in
Yeah.
there.
If you die on the way because you chose to go somewhere 30 minutes further away than I told you you needed to go,
That's on you.
not my fault.
You have to live with that. Oh, wait, that's
Most
fine.
of them, once you manual notifications of when you're closer to the longer they go without immediate treatment.
I take my meds.
And it can cause other complications. Most of them will actually, once you explain it to them, are fine with you don't go to the facility.
Most of the time. What if they're cognitively impaired and they don't understand anything that you say?
No, I'm talking about family. 'Cause it's
Not like
family,
that
then
today.
it's usually-
Family doesn't matter.
But it's usually family that gives you the, and you're like, no, this is why we need to go here.
You ain't gotta listen to family.
Well, sure,
Where's my
but
mom?
you still gotta get the patient out of the house.
Mm-hmm. Yep. No, if you got to, call law enforcement.
Oh, there you go.
They won't let me take this patient that is dying. Ma'am, step back and they will help you get the patient out. Okay, there's tools around you, but please take them to as close facility as possible, if it is possible, as quickly as possible. Scene flights versus ground transport.
If your ambulance gets stuck, it might be faster, but if you're gonna wait a long time on the helicopter to get there, and then it takes however long for the helicopter to get somewhere, do they have a third trip and probably.
So helicopter, I'm gonna pick on them because I used to do it, so. When you call and request a helicopter, and they tell you, we got an ETA about 15 minutes, when they actually show up,
25 minutes later.
25, 30, 45, it's whenever
Well,
they
it
decide to
takes
get out of
about
bed.
30 minutes just to check off their helicopter flight.
Yep. All right, so they gave you an ETA 20 minutes. You picked up a patient that called you and said, stroke-like symptoms, right? That started 20 minutes ago. It took you guys 30 minutes to get to them because they were out in the county in some, I don't know, something playing a banjo in the corner. Okay, so it took you 30 minutes to get out there. They were having the symptoms 15 minutes before they even called your dispatch. So we're how far into this already?
45 minutes.
45 minutes. Now we did our assessment. We fooled around with them. Now we've done 10 minutes. And now we're gonna make a transport decision. We call the helicopter.
That's a smart idea.
Okay. Helicopter does all of that little foolery and then they say, well, we gotta check weather. And then they say, okay, yeah, 5 minutes later, they'll call you back and say, okay, they've accepted. They got an ETA of 20 minutes. Now where are we at?
An hour, hour 20.
About an hour and 20
hour
Okay.
20.
ish. So we're an hour and 20 minutes into this stroke. Whereas it could have took us 30 minutes just to get them back over here. Helicopter still ain't even landed yet. To fool around in the back of your ambulance, make a big old mess and then leave and say, hey, Danny's clean up my mess, right? And then they gotta do their walk around, start up the helicopter. 5 minutes later, they finally take off. Now they have what? They have transport time. They have flight time. Anybody know what the flight time is from here to Little Rock? Or
45 minutes,
here to Washington Regional?
50 minutes.
That might.
I don't know. I haven't flown. Let's see, I flew up in Harrison a few times,
I'm just thinking that.
but I didn't fly most at the top of the state, so I don't really know what the flight times are, but anybody?
No.
So roughly to get them to another facility, they're gonna have at least 30 minutes to an hour flight time.
Mhm.
So then where does that, by the time they get to that facility, now where are they at?
Close to 4 hours.
3.5, 4 hours. We've dinked around, got rid of almost all of this patient's time before they can even have the chance of medication, whereas I could just driven them 30 minutes down the road and they'd have better what?
Even 45 minutes.
Yeah, they'd have a better chance of survival. So these patients, I'm not saying not to call. There are times when you do need to call and use the helicopter and use them as they're supposed to be used. But also think about your patient and know your window that they only have 4.5 hours from the time of it starting to get the medication, but they have up to 24 hours to get it mechanically removed. Okay, so they could come here, get the medication, and then afterwards, they can still be transferred out and they can still get the thrombolectomy later. Okay, but we gotta at least try and reperfuse it first.
Same.
All right, this also goes with the bypass or not bypass. How much time you got with that patient. Shorter door to needle times, that's ultimately the goal. Door in, door out times. All right, so it's for our hospitals that need to be not IR, so it's not interventional radiology, that's the word I was looking for. So for like a facility here, okay, you brought them here, we need to work with them and run hot when they call you and say, hey, we have a transfer, it needs to go out, it is a stroke. We still need to run hot on those, get here as quickly as possible, and when you're leaving, have short times here, you know, don't get a good report, but at the same time, we don't need to dink around and wait. And just kind of lollygag and use the bathroom and find me a snack or get a drink for the road or whatever. Okay, we should be filled up. We should be ready to go take a transfer if we have to. Get these patients to where they ultimately need to go. If it is an LVL, they still have 24 hours to go, but say they got that medication right at the 4-hour mark. All their labs come back, it took a while to find placement, and now we're sitting at, I don't know, they sat on them here for 12 hours. So it's 24 hours from the last known well time. It's not 24 hours from the time they got the medicine. Okay, so we already used 4 of those hours and we only have 20 hours left for them to still get that thrombolectomy. So we need to run hot on this. All right, what the ED needs to know, most of us know how to give a patient report, so I'm not going to go into too many details, but they need a brief history of what's going on with the event, the BFAST exam, and basically what they failed on the BFAST exam. We don't need a big old long drawn out story. Hey, patient was saying that they just were watching TV, they weren't feeling really well. And that's what we got the original call for with weakness. We got there, we did a BFAST, we found that they have left-sided weakness to the arms and the leg. And blood sugar is this, last known well time is this, I got an ETA of that.
And blood pressure.
Subjective. Change can change again before it gets here, right?
Below 220, you didn't treat it, no.
There you go. We're good on blood.
No treating and blood pressure. All right.
Not so many.
So, pertinent past medical history. We don't need to know that this patient has gout. We don't need to know that this patient had, I don't know.
A tooth pulled 6 months ago.
Yeah, we don't need to know that. Well, maybe a little bit further out from 6
Okay.
months ago.
Okay, 8 years ago.
Okay, 8
Is that
years
better?
ago. We don't need that. Yeah.
Stubbed a toe when he was
Stub
12.
toe, whatever. Okay, pertinent past history. They have hypertension. They recently had a stent placed within the last 6 weeks. Or they had a history of DVT and they've been taking some sort of blood thinner and they haven't been able to fill it. Okay. Doctor put them on Eliquis because they have AFib and they're on a fixed income and they can't afford Eliquis, so they just didn't get it filled this month. Okay, pertinent history to how this may be affecting their stroke and their care. Break time. Anybody need pee? Get a drink.
What you got?
We usually do about 10 minutes and then we come back.
Cool.
Is that
10
okay?
minutes.
Look at
We
you
are
with
having,
the freight time in there. That's awesome.
we are on slide 30. This is exactly your halfway point. So
Take your break.
take your break. We're gonna go ahead and start. Unless we need to wait for our quiet one to come back.
I'm gonna tell her you said that.
All right, so we're gonna get started. We're gonna talk about pediatric strokes for a second. Pediatric strokes, hopefully none of you have to transport them. I know a lot of people don't like to transport pediatrics anyways. Some people, you know, it's a special breed that like to take care of kids, but me, it doesn't bother me too much. But it definitely helps to have, you know, a background. So pediatric strokes, my volume is low. Not talking loud. We're in the same spot.
That's a good spot.
There we go. All right, we'll try this. All right, so pediatric strokes. Possible signs and symptoms, as we can see, most of them are going to be, most of them are pretty much the same as adults. Headache, hypertension, slurred speech, so hemiparesis, aphasia, facial droop, vision changes, altered level of consciousness, and maybe some seizures. Now, there's three of them that are starred up there. Hemiparesis, aphasia, and facial droop. These are very concerning for stroke signs in pediatrics. All right, usually at this point, they are having a pretty severe stroke. So most of your kids are not gonna, if they present this way, you know, we need to be treating them pretty rapidly. Not that we don't with all of them, but those three are kind of ominous signs as far as your pediatrics go. Guidelines for these patients, we're going to treatment kind of depends on the type and size of the stroke. Most kids don't get a CT, they get an MRI. All right, so if your facility cannot do a stat MRI, we may have to think outside of going somewhere else that can. All right, not saying that they won't see, we can still do them, but a lot of times they get an MRI versus CT. CTs they don't require sedation. MRIs do, because they have to stay still for so long. CTs. How many of us, anybody been around or have a kid that they've tried a CT?
Yeah.
They don't sit still, all right? And they move their head, or maybe they just move slightly and then they move slightly back, whatever. It's really hard for pediatrics. So it's harder to get a clean image. All right, so they may not necessarily, they should be able to see it lead, but even with movement, there can be a discrepancy to be able to see if there truly is a bleed or not. Which take me to the medication. All right, we use Sedex Place up here, or we use Alteplase. Okay, all right, so the Sedex Place, nobody under the age of 18. Okay, so that was not pediatric anyways, right? So Alteplase, under age 12, they can't receive it. So if they're in their teenage time frame, they may be more likely to still get some sort of medication, but it's going to be done more likely at a children's hospital. Okay, these patients need to be close taken to the closest appropriate facility. These ones would be the ones that I would be more willing to air flight to a children's facility as opposed to bringing in here. Okay, I don't have, to my knowledge, most of the facilities that are in our program, you know, stroke ready hospitals, they're stroke ready for adults. They're not stroke ready for children. Right. So use your critical thinking and know where your closest facilities are, what is appropriate for the patient that you're treating. Another consideration for pediatrics. All right. Remember how I said that we want to keep these patients, stroke patients for adults, we want to elevate, right? 15 to 30 degrees. I don't expect you to have a protractor, but this is about enough for you to keep the cardiac monitor up underneath the stretcher, right? The head of the stretcher. So that's about 30 degrees. For pediatric patients, we want to transport them flat. All right. This is because kids, they're different when it comes to their physiology, not just little adults. All right. Their physiology is a little bit different and they fuse better when they're flat. Okay. As opposed to when they're up.
A little growth.
And so they're little gremlins.
She
Little
felt
gremlins.
Miss Quiet
Yeah.
earlier, you
Miss
missed
Quiet, she had to go get her cake.
I did. That's my.
We was talking about cake yesterday at work, actually. So, anyways, frequent neuro assessments on these patients, you should be doing that with your adult patients as well. But pediatrics, they require a little bit more frequency. Because what do we know about kids?
They're good till or not.
They're good till they're not. Well, adults are kind of that way too, but, all right, so kids, they have a longer, what? Compensatory mechanism. They will compensate for a very, very long time, and then all of a sudden just drop. All right, adults, they have a shorter compensatory mechanism. They'll compensate for a little bit, but then they gradually drop on you. We have a longer time in that pericensis for adults than we do with kids. All right, I like to think of it as like the elephant. If you look at the elephant, it's very long, they got a really long back, right? Then you get to their head, and then what happens? Just drops, right? So for pediatrics, you have a really long back, and then the trunk is just, they drop straight down. And that's how I think of pediatrics. So, so you have the tendency for these kids to just crash on because you don't know how long they've already been compensating. All right. Let's see. I touched on this earlier. A large majority of these strokes in pediatrics are caused by aneurysms or other vascular malformations that they were born with that they didn't know about. Right. So let's have kids in here. It's not like when you have a kid, they just send them, and they do a once over and get an MRI or a CT of all of them, make sure they didn't have any problems, right? Unless you didn't have problems during a pregnancy, you're not going to look for it. Okay. So we have to be vigilant with patients and make sure that we're checking them and assessing them more frequently.
So on that, the assessment, I was thinking, I don't know if I would be able to do scale on a pediatric. So do you have any suggestions other than like a gaze, a deviation?
So, so when we think of kids and we have altered mental status, right? And whether or not they are age appropriate to what they're supposed to be doing. If I have a 2-year-old toddler, right? I know age appropriately, they're going to want to be clinging to who? Mom, or their care provider, whoever they're normally with, right? If they're not clingy to them and they're wanting to push you away, doesn't necessarily mean it's not a build trust for them or something like that, or abuse that we kind of think about like that. But that can be an alternate. They're not age appropriately acting. Okay. As far as physically, when they cry, what happens with your face if they're crying? When we cry, we still see some sort of symmetrical something, right? If it's off, then we can go off of that assessment. If we, you can blow in their face. If our little ones, we taught a little one how to swim, you can hold their breath, and before you throw them under the water, right, blow in their face. And that makes them do what?
Hold their breath.
Hold their breath. Okay. It also makes them clench their eyes. Blow in their face. If they can't squeeze their eyes, or they do that and only one eye closes, so that's an assessment process. Okay. As far as the arms go and their extremities, we can kind of hold them up. If they're a toddler, they can kind of follow some commands, right? Have mama do it. Hey, mom, have them hold up their arms. They can't hold up their arms or on one arm. Okay. Use the parent that they're comfortable with, if they're comfortable with them, to help you with your assessment. Right? They may not be comfortable with you, but they'll be comfortable with mom, and mom might be able to tell them what to do, right? Same thing with their legs. Can they pick leg up? If they're walking age group, okay, mom have seen them walking a lot, or are they doing something different when they're walking? Have they reverted back to crawling, scooting their butt? Like, what are they doing that's different? Okay. So a lot of the assessment information is going to come from the care provider that is there, or they're going to be like helping you with your exam. Does that answer your question?
Yes.
Okay. Finger stick blood sugar on these kids too. So if they're super little, hopefully we're not seeing some of this in like babies, but even in toddlers, their hands are little, right? So it's hard to get a finger stick on them. Take their sock off, use their heel or their big toe, preferably their heel, and you're going to go on the lateral side, the outside of their heel. Right, clean that real good. Stick that with your lancet. Give it a little squeeze, it'll bleed for it, okay? That's usually where they draw labs to on babies. they get capillary bleed from them and they just keep milking. It'll bleed pretty good. Questions? All right. Touched on this already. Keep your patients flat for your pediatrics. Get access, large bore if possible. I know these kids. I'm just gonna say it. All right. Don't fool around with 15-20 minutes if you are not comfortable doing pediatric sticks. And being confident to be able just to stick their foot or their hand and get one. I'm talking the little ones. Your teenagers or whatever, you know, we can get them in peripheral IVs, but your little ones, don't fool with it. Go ahead and just get an IO in them because that is what? Big, ain't it? All right, it's like having an 18 gauge kid. All right, so just go ahead and IO them and then you have good access for them. Yes, I know they're awake. But in reality, IOs don't hurt more than an IV does. Okay, the part that hurts the most is when you're flushing it. Use a little bit of lidocaine in your flush. It numbs that feeling a little bit, and then you can push whatever you need to through that. Vital sign parameters, most of us, unless we transport kids all the time or are very familiar with it, you're not going to know your vital signs like you do adults. But for the most part, anything that's school age. What do we think of when we say school age? How do I break that down?
6 to 18.
6 to 8, all right, they're going to school. Okay, they're in first grade.
Oh, 6 to 8, okay.
Okay, so they're in school age, they're kindergarten, first graders. Their vital signs tend to start being more like adults. Their normal ranges are gonna be out like ours. Anything under that, your toddlers and your infants, that's where your parameters are a little bit different. Okay? Questions? Also, your Broslo tapes have your vital signs on those, so if you need a quick reference or something. And then, like I said, on the last slide, transport these patients to the nearest facility that is appropriate, and more than likely, it's going to be a children's facility.
So this is where we want to fly.
Yes. Oh, yeah, you were out getting your cake when I said that earlier.
Actually, no, I was going to the back room.
Oh, okay.
And then.
All right. So yes, these would be more of an appropriate to defy these patients. Especially since they can't get what? They can't get medication, right? So our 4.5 hour window is not as critical. We have that 24 hours regardless, right? But we still want to do as quickly as possible for these kids. All right. What came first, chicken or the egg? We don't know, right? So is it a debate? You can go either way. This is where we do our detective hats. Same thing here. This could be trauma, or did the stroke lead to the trauma? Okay, we don't always know. I had an incident at one point. It was I was working at a facility on a truck off I-40. A truck, she came in, she was swerving all over the place, and apparently she sideswiped a car that's trying to go past her. Okay, with a trailer, she didn't hit with the truck part. Everybody was okay, but the big truck driver, just didn't seem right. We were checking on her, asked for questions, and she just didn't seem right. There was no spidering on the windows, no trauma to her truck itself. So we were like, what the heck? We transported her anyways for an alternate status possible stroke. She ended up having an LDL. So what happened was, more than likely, she was having a stroke, and that was what was causing her to drive erratically. Okay, and then it was the trauma. So we need to ask good questions. We need to get as much of a history. We need to be able to think outside the box. It may not have been that the fall is what caused the stroke. The stroke could have caused the fall. Okay. Or was this grandma that was with her 30 foot of oxygen tubing throughout the house on her 1 liter, you know, that she thinks that she needs, and did she trip over the O2, or did she tubing, or did she end up having a stroke, and that's what caused her to fall? So we got to be vigilant of our surroundings. We have to ask questions and put our detective hats on first to know what we're treating.
So we have a question in the chat that asks, is Le Bonheur pediatric stroke?
Yes, yes, they are. I have a friend of mine that flies for PD flight, and I actually reached out to her yesterday, as well as a friend that works for children's flighting. I've reached out to both of them yesterday, and they're gonna be getting me some neurologist contacts at both facilities so I can talk to them and get a little bit more information, add to these slots for pediatric strokes. I guess what I have is not as good as it could be. So if and when that happens, I will reach out to you guys and let you know anything. Arkansas Children's is closer.
This is Lebonner is
Oh,
closer
yes,
than ACH.
yes, Levon, you can take your pediatric stroke patients to Levon. They are ready. Then you have children's. Then you have, what do you have, children's up there in Springfield? Yeah, Springfield.
Washington. Or is
I
it
think she's
Children's?
talking Springfield.
Springfield.
In Missouri.
Gotcha.
And then the next closest one, it's not really close to here at all, but if you were on the other side of Arkansas, the next closest one would be Vanderbilt.
Yeah.
In Tennessee.
Yeah.
All right, so those are kind of your four right here for you guys. All right. Okay. Question. Which one are you gonna run hot? For those of you that are driving, I'll go ahead and read it. You have a 2 o'clock in the morning nursing home patient that was found in the bed and it is a code blue. Second one is you have a 25-year-old with a self-inflicted gunshot wound to the head that becomes a trauma code as you are assessing them. And then you have the third one, a 40-year-old with an acute onset of slurred speech, arm weakness that started 15 minutes ago while he was in a meeting for work.
First one, if they were family bed, like, once the nursing home, by the time you get there, they're gonna have to.
We don't know what found means. Are they like oriented? Are they dead? Like, we don't have status of that first one.
It's a code blue.
They're found in the bed and is a code
Yeah,
blue.
it is a code blue. Okay.
Oh,
All the things.
I've seen first.
Basinger says 40-year-old.
I agree.
Being that this is a stroke class, it's probably fair to say that the last one that's having a stroke, you should run hot on. Reason for that is the 2 o'clock in the morning nursing home patient. They may be in a code blue, but probably just a DNR that they didn't know. Or, right, they're technically already dead. When the CPR is going, they're technically already dead, right? 25-year-old self-inflicted gunshot wound becomes a trauma code. Yeah, you're probably gonna run hot on it. However, they are technically a code, therefore they are technically dead, right? And wanted to be since it was self-inflicted. And then you have your 40-year-old that you can potentially have a good outcome for, right? We can do more for this patient. This patient has a better outcome of survival between the three. The trick question, technically you're gonna run hot on all of them, but being it's a stroke class, we're gonna pick the stroke patient, okay? All right. Here we go. This is the data portion. This is the part that gets a little bit boring for everybody. This is why we take a break beforehand. The average time from the patient having onset of symptoms to getting to the ER is 17 to 22 hours. Not minutes, but hours. Reason for that is 42% of the people over 50 don't even recognize a single sign of this of a stroke. 17% over 50 can't name a single one. So 38%, these are national numbers, they're not Arkansas numbers, okay? These are national numbers. 38% only call 911. And 20 to 25% arrive at the ER in time for thrombolytics. What does this slide itself tell us?
We need better stroke education.
We need better stroke education to who?
the
Public.
The public.
Yeah.
Which is where you come into play. All right, you guys have to do your part and take care of your community and make sure you're educating as well.
I'm doing it.
Impacts of stroke. According to the CDC, in October, when they posted their most recent information, stroke is now the leading cause of death in Americans. It is succeeded cardiac. All right, according to the CDC and their information they had on their website. Back in,
It makes sense, but as
October.
soon as someone has chest pain, they're calling for an ambulance.
Mhm.
For cardiac.
But did we remember? How many of us in an EMS? More than 10 years. One. And me, okay. Back in the day, STEMIs weren't, I mean, they were, but they weren't, okay? 12 leads on the ambulance was a new thing, okay? So back in the day, we had these dinosaur cardiac monitors that, I don't know if maybe you guys have seen them, but they literally look like a small computer and they're screen about 3 inches by 3 inches and it gave you one lead.
Paddles were bigger.
And the paddles, yeah, the paddles were actually bigger than your screen. Okay, it was heavy. It weighed about 40 pounds or heavier. And you had to lug this thing at patients' houses and the paddles usually didn't stick to it. So they fell off and they're flopping around like this as you run in the house. Okay. So, but how did that get better?
Technology.
Technology and community education. We pushed the education out to the public, right? Heart attacks, please make sure you're taking your aspirin as soon as you start feeling chest pain, this and that, right? We had to push that information out there. Same thing with strokes. Now we need to push, we should have been doing, but now we need you guys to be out there pushing the stroke information to your communities and helping them understand that this is just as severe as having a heart. Okay.
Stroke is standard, no one for your patients in the nursing home statement, they'll take it, isn't it?
Yes, because they're, most of the time, what are our nursing home patients doing? Besides that.
Black tag.
Yes. Is, can you get our screen back?
I gotta
So,
be the serious one.
so besides dying, yes, technically, we are all doing that right now as we speak, as it's tick off of our life, but, okay. But besides that, what are they doing? Are they up moving around much? No, they're laying in bed, so they're more susceptible to blood vessels. Yes, and clots, blood clots, all right, bed sores, which you might be if you don't change positions in your chair, okay? So,
But stroke was the number one reason people.
correct, which is where I'm going in like 4 points in just a second. All right, so 1 stroke every 40 seconds happens in the United States. 1 death approximately every 30 minutes from a stroke, or 3 minutes from a stroke. That's a lot of strokes, a lot of people dying. More than 795,000, so close to 800,000 strokes per year in the United States. 87% of those are AIS. Take a shot at it.
I have no idea.
Acute ischemic strokes. Remember that very first slide that I talked
Okay.
about? Yeah, there's gonna be a test. There's gotta be a test. All right, acute ischemic stroke.
Awesome intelligent shade.
In 2014, CDC, 38% of the hospital people are hospitalized from strokes under the age of 65. And then $56.2 billion in United States goes towards stroke-related medical costs, which is where that nursing home comes from. All those nursing home patients, those stroke patients that end up going to the nursing homes, where's that money coming? They have to sell all of their assets and everything else just to even get into the nursing home because they won't accept them in the nursing home. They can't have a house. They can't have anything in storage. They can't have money. They can't have none of that. It all has to be signed over to the nursing. Or sold well before they even had a problem, but most of us don't know that we're fixing to have a stroke and have a chance to sell all our stuff.
I think we have a stroke tomorrow. Let me sell this stuff.
Right. Okay, so that's an issue. So then our tax money is doing what? Paying for them to stay there. Paying for them to get back and forth to their hospital treatments. Right, for their rehab. Paying for the staff to have physical therapy, to have occupational therapy, for them to have their rehab. This is coming out of all of that money. This also includes, now they are not able to contribute work. They can't work. All right. So now they're not contributing to the funds of the United States either. Okay. So it is important for us to keep a little bit more money in our pocket if we go out there and we educate a few people, right? Keep them from going to the nurses.
Do you want to know a fun fact?
Yeah.
Absolutely. It's not really fun, but just so that you recognize the fact that stroke patients are getting younger and younger. the median age in Arkansas in 2023 was 47 years old.
Yeah, smoking.
This is not countrywide, this is our data.
Just
from
Arkansas.
from our program.
Poor diet.
Or not, yeah.
Yeah.
Well, there's
Well,
a lot
Arkansas is
factors. There's a lot of
overweight
factors
now, like,
go
whole
in.
United States is overweight.
Yeah.
And even there are different kinds of birth control, certain kinds of birth control. Depending on the person who has stroke. There was somebody who was 20-something years old, somebody I knew, and she started early 20s, maybe 21, 22. And she went in and she looked in the mirror and she started to recognize it. One people was different stuff and she felt pain. And so she come to ER where they were close to where they were living in. And turns out she was having the thoughts.
Yep. So medications, so technology, pharmacology advances, they are good, but they're also bad. Okay, so we, like you said, birth control is an issue. We know if any of us have been on birth control, what is the issue? They tell you if you read the instructions on your medicine or whatever, then one of the possibilities is that you get a stroke. Okay. So there is goods and bads about advances in technology and in medicine, but primarily the one free thing that we can do for people is educate. Okay.
Sarah and Erica are very good at that, and I try to push it out to our first responders. And I'm not bragging myself, but within the last 5 years, I've really seen a change in our first responders that are treated on scene before we get there. I think it's just education. They didn't have the knowledge beforehand.
And I have a class too that I can do for just first responders. I do it for some of the fire departments, first responders that are out there. A lot of volunteer fire departments and stuff, they want classes so they know how they can better help you guys before you get on scene.
Okay, well, I may be reaching out to you
I'll be
then
awesome.
during the summer.
Yeah.
Okay, thank you.
All right, so touching back on some data. Per second, per stroke, you're losing, per second, you're losing about 32,000 neurons. That takes about 8.7 hours off of your life. Per stroke, you're losing approximately 1.2 billion neurons. And this age you 36 years per stroke. Alright. So how old, you don't have to tell me how old you are, but if you were to subtract 36 years,
I would be bored again.
well, there you go. So if you were to have a stroke today, that'd be pretty old. You're lucky. What is 40-year-old?
It's stroke of life.
All right. So time lost is brain loss, just like when we taught our STEMI classes and we're learning in EMS. The faster you can get patients in the hospital for PCI to get that stent placed or whatever, right? Same thing with brain. Faster we can get them to the medication or to get an actual thrombolectomy, the better they are. EMS impact. EMS plays the biggest role here, in my opinion. Of course, my roots are in EMS, but in my opinion, they take the biggest role because we are out there with the patients in their houses. We are out there and we see them more. We see them when we go to the restaurant, sit down and eat in the ambulance and sitting outside. Or we see them when we go to the grocery store, pick up our food so we can take it back to the station, whatever, right? We need to educate our patients. We need to talk to them. Don't avoid them. Don't go the other direction. Okay, we just want to be friendly. Roughly 400,000 patients call EMS in the United States. This is not enough people calling 911. All right. I know it feels like we run all the time and it's like, how are these people not calling 911? But they're not. All right, they're coming in POV or they're not coming in at all.
It's the same ones that keep calling.
Yeah.
That's my problem.
It's a frequent flyer that's standing out there with their trash bag clothes ready to go.
Yes.
All right. Hey, I'm right here. You what?
Need more education so they can actually call for these things.
Yes, yeah.
Or maybe they just don't know 911.
Might be the only number on their phone. Maybe they ain't got no minutes. And that's all it's not. I ain't got no minutes. All right, that's the only number that works. Okay. Recent our Saves program, that's us, revealed that patients arriving by EMS with a code stroke notification got to a CT sooner, as opposed to those coming POV or EMS without a code stroke. Remember, the last known well time less than 24 hours, they can, it still needs to be called in as a code stroke. So even if somebody up and they're outside that window of 4.5 hours can't get medication, you still need to be calling in a code stroke to your facilities and getting that CT right away anyways, okay? Here's the data, here's the numbers over the last few years. I got this from one of our colleagues in the program. So this is since 2019 to 2023. I don't have the data for just this last year that just finished just yet, but it's easier to see on this slide. So put it in a graph for you. If they came in POV, you see it in the orange. Their CT time is roughly 24 minutes back in 2020. And in 2023, it came down to about 19 minutes, but it's still in a 20-minute time frame, right? In 2020, EMS, no stroke. So you brought them in, but you didn't call in a code stroke. It still took them in 2020, 20 minutes to get for CT. Okay, this is through our program. This is not just this facility, all right? In 2023, EMS, but no code stroke, you actually took longer to get that CT than patient coming in POV. And in purple, you can see right there, if EMS calls in a code stroke, in your report, you say, hey, I have a stroke. Across the board, we're almost within that close to 9 minutes, 9.5 minutes. We're under 10 all the way across the board. So what does that do? What does that tell us? If we do our job,
We get better outcomes.
we have better outcomes. If we're not complacent, because we're like, it's our 17th call of the day and it's 3 o'clock in the morning and I really just don't want to deal with this, we're just going to go. Right? So we need to do what's right for the patients even when we're tired. Stroke bands, how do we get this information? Well, we get this information from your stroke band. So we need you to put your stroke bands on these patients. We need you to not only do that, but we have to have you document it in your documentation. What do we use here? ESO image trend. I love it. All right. So in image trend, I know from using it, if you put in your primary assessment or your primary chief complaint some sort of stroke complaint or symptom, what does it make you do?
Red flags.
Red flag, it won't let you start without putting a stroke band in. Now, if we know the system does this and we're like, I really don't think it's a stroke, so let me find a different complaint that doesn't automatically block that. Okay, we're not gonna do that. Okay,
Yeah.
don't change your complaint just so you don't have to put a stroke band in there. Okay, don't make your charting more difficult. Just do it as it's supposed to do. Put stroke band number in there so it helps us get the data we need, and it helps me make these classes better for you guys.
Well, and even an image trend, if you have altered mental status, depending on what your vital signs and everything else you put in there, it may actually knock the stroke scale off of there.
Correct.
So just because it flags for stroke scale, because you put altered mental status or something in there, doesn't mean that will fall off based on your other information. You may still have to put one in there. Anyway.
So when you, if I remember correctly, if you put alternate mental status in there, then it opens the question of, did your stroke assessment be done? Right? And if you put no, what does it do? You don't have to put a stroke band in. What is alternate mental status? Should we be doing stroke assessment on?
Yes.
Well, if it has, glucose is one of the things that checks that too. So with your, even if you have a stroke scale in there, it may still flag because it wants that glucose and some of the other information. It wants to see vision information.
I understand. I get that, but there's ways for you to be able to avoid putting that stroke information in there, right? Okay. But even if it's an altered mental status, or even if it's dizziness or weakness as their only complaint, we should be doing a stroke scale on these patients. So we should be saying yes, and it should make that the stroke band number populate for us to get that information. So if there's any question, any doubt that this could be a stroke, even if it's just one symptom, and they don't have the telltale signs of facial droop, or they don't have the telltale signs of hemiparesis, or they don't have a telltale sign of, I don't know, completely unresponsive. Okay. Go back to our other one when we talk about the brainstem strokes, and their only complaint is nausea, vomiting, and dizziness. Right? Could be stroke, the stroke system. It doesn't take 15 seconds to have somebody put their arms out, right, smile, and bring your legs up. Okay, so just do one and make sure that these patients, and even if you call it in a code stroke, or you put a stroke band number on there, and you don't think that it's a stroke, call it into the hospital. Hey, I don't really think this is a stroke, but I'm gonna let you know that they did this, and it could be, so I went and banded them. All that's doing is making your ER get them the CD that they ultimately end up needing. Okay? It's not an extra, it's not wasting your time, and it's not a waste of the patient's time. We ultimately need to go ahead and do that. So what else do we get from stroke band information? I get your scene times. I get whether or not you performed an exam, even if you said no on the paperwork or whatever, I still need to know that you didn't do it, okay? Code stroke, it tells me whether or not you guys did notify your ER. And then it also tells me if you are one putting the band on the patient, or if the ER is having to put the band on the patient. And then it also gives us treatments that you did on the scene or en route. So did we have to treat blood pressure? Or, was this a trauma patient and, they fell or whatever. Okay. So just like your trauma bands that you guys use, maybe we don't always call trauma center, right? We have levels of our trauma, right? So if it's a level 1 trauma, we know that we need trauma and they're probably going to a trauma center, yada yada, right? But if it's a level 4 fall because it was Granny that was in the wheelchair and she just kind of tipped over, but she didn't hurt nothing or whatever, we still put a trauma band on her, right? We just don't call it trauma. Same thing. Put a stroke band on these patients. It doesn't mean that they automatically are a stroke.
Does it matter which side you put the band on?
I don't care. One on them. Put it on their ankle. Don't care. Don't put it around their neck. That's just because that's neck.
Oh, final one, nice to put two, but anyway,
I don't want to know that that it only takes 2 to go around somebody's neck.
I was just guessing.
Oh. All right. So just put a band on your patients, just like your trauma patients. Just because you put a band on them does not automatically make a stroke, but it gives us the information that we need so that we can make our classes better and make our program better. True.
What if it's on?
All right. Stroke documentation. What we need to see in your documentation. Again, stroke bands. I need you to put them in there. Was the stroke exam performed? If yes, I need to know which one. Yeah, I would like it to be the BFAST, but I really don't care which one. I need to know what your symptoms were. Are they positive or negative? Okay. If they're negative across the board, great. Fine. Okay. I just need to know the information. Scene information, your scene or your inter-facility transfers, that's what ITFT stands for, just in case. Inter-facility transfers, that means it's transfer out of here going to another facility. We need to know that. We need to know if it is a scene or if it is an inter-facility transfer. I think it is a box on image trim that you put in there. If not, if it's not a box, make sure it is put in your narrative that they called for inter-facility transfer from such and such hospital to such and such hospital. That at least will cover you, and I can get that
Do we need
information.
the symptoms that they were having?
Yes.
In narrative?
If their symptoms have resolved because they've gotten the medication, or they just resolved on their own, whatever, we still need to know what their original symptoms were. Okay. Accurate time stamps. We back into the back of the bay, which that little clock gives us the best time. Okay. Don't go in with your computers closed or whatever. I need to know as best of time frames as possible. I know I'm just as guilty of my computer stays closed until I start charging. I'm like, I was probably there like 5 minutes. Maybe I was there like 7 minutes, whatever, right? And I just make up times off of my dispatch time and then as I go. We need to be as accurate as possible. Okay. Treatments on scene and en route. Again, I need to know if you've treated the blood pressure. I need to know if you didn't treat the blood pressure. I need to know if you started an IV or if you didn't start the IV. Document your treatments. Did this patient need fluids? Did this patient go on the cardiac monitor? Whatever. Okay. EMS is really the on-ramp and the off-ramp for these patients. I say off-ramp because ultimately what happens with these patients? They're discharged home and they've had a severe stroke and they're going somewhere, you know, like you said, the nursing home. Who gets them there?
Family.
EMS. Alright. So EMS gets in there, right? May not be you guys, they may be being discharged from wherever, the bigger facility, but it's still somebody, some EMS is taking them to them. Right, so ultimately EMS is the starting point and the ending point for these patients.
Particular day on what percentage of your stroke patients are actually hypotensive when you get to it.
Hypotensive? I don't have any of that data.
I've just seen it at least 4 other times where someone's had to be given because they were actually hypotensive.
And if they are hypotensive, the only thing that we would ask you to do is treat them, you know, as appropriately, but at that point, then you can only let to help with their perfusion. We only want you transporting them in that 15 to 30 degrees angle if they're systolically above 90. If they're less than that, obviously, we need to treat the patient, lay them flat, and if we gotta put them in a slight Schulberg or whatever and get some fluids in them, we gotta do that. We gotta perfuse the brain. Okay.
And your only other thing with that is if you happen to lay down such if you see him starting to vomit or something, of course you gotta deal with that. That's your minor hemorrhage, and it's just where you're gonna see that. Seems like.
You can, but some of your acute ischemic strokes, one of their biggest symptoms would be nausea.
No, I'm saying when they actually are active with.
Either way, even if they're just nauseated, you still gotta worry about airway protection, right? And then doing our appropriate neuro assessments every 15 minutes to see if this goes down and if airway control is something that I need to do. But I need to knock this patient down because they're no longer able to control their secretions. And they're now a choking person, right? For it, they can asphyxiate or they can aspirate or whatever. All right, stroke designation. We talked about this a little bit already, making sure that we are going to the appropriate facility. Arkansas Department of Health determines who is a stroke-ready hospital, stroke able. Know your surrounding, know your area, know what the capabilities are of your facilities and what they can do, and take your patients to the appropriate facilities. This will help with designation, destination decisions. Local EMS protocol may dictate that you take them to a specific place. It may be up to your protocols, it may not be, they may leave it up to you. But don't let the family talk you out of going somewhere that is appropriate to the patient. That's pretty true. All right, so this is a slide, I don't want to see as big as I can make it, but this is all of our facilities that are in our program. All the red ones are spoke sites or what you would call your stroke ready hospitals. Okay, so they can do a CT and they can give the medication. The blue ones are spoke and receiving sites. So these are our sites that still do everything just like here. They can do a CT, give the medication, but they also can receive your patients post TNK. All right, so these patients have neurology there, they just don't have neurosurgeons. All right, so they can receive them and they can monitor them, but they cannot do intervention neurologically there. And then our receiving sites, they are not those sites, they are only receiving. We have a couple of those, we only have 4 of those. 2 in Little Rock, 1 up there in Washington Regional, and then I think it's Wadley down there in Texarkana. Okay, those are where neurosurgeons are, so they have IR, which is interventional radiology. They go and do the thrombectomy. Right. So if you're transporting a patient just because they had post TNK, they're not being admitted, they need to go somewhere to be monitored for neurology. You need to ask, hey, is this patient going for a thrombolectomy or is this patient just going for neuro observation? Right, because that's going to be determined where you're going a lot of times. This is just a list of them. Hope you can read it and bring your glasses. This is as big as I can make it. It's really hard to even read on my screen, but it's a list of all the places. If you're curious, you can get on our safe website and look it up. Right. U.S. stroke affiliated hospitals are RCHC is still on my slide.
It is.
Alright. This is, they must be able to provide stroke education, which is why I'm here today. And they have to include you guys in your PIQA, alright? So you should be being, somebody from your service should be invited to get this information quarterly to help make the program a little better and easier for you guys, what you need from them and what they need from you. Should be included, you guys should be included in your public outreach. All right, so this is our education, public education, try and get out there and do that. You don't have to have the facility with you. You guys can do your own public education. If you need resources, pamphlets, whatever to do that, get with me, get with Robin, we can get you some stuff and get out there and do your own little minute stands, okay? All right. Treatment options, current guidelines, IVL to place or to next place, last known window, last known well time, the window is 4.5 hours. Like we've been hounding throughout this class. FDA only approves it for 3 hours, but our program uses it out to 4.5 hours. Okay, so don't worry about the 3-hour mark, all you need to know is 4.5. Mechanical clot retrieval, this is the thrombolectomy. You have up to 24 hours from the last known well time. This is not the time from when they got to the hospital. This is not the time that you guys were dispatched. This is the last known well time, just like it was for the other. You can't see this very well either, but they are protocols that our neurologists have already written for you. Okay. These should be coming when you're doing a facility transfer. They should be coming from this facility and going with you with a patient sticker on it. All right. What these are is guidelines for you to be able to treat the blood pressure after they've gotten to next phase. Remember I said we don't want to really treat it before.
Right.
After they've received this medication, it is imperative that we keep these patients under the 195. Okay. Like 185 to 195. It's systemically in there. All right. So if they were not hypertensive while they were in the hospital, but this gives you the protocol to be able to and the parameters to use the medication on your truck to keep them from going hypertensive during transport. If your patient was on a cardiac drip when you picked them up and they didn't have to continue it, they had to pause it because the patient was staying okay, they didn't have to keep it, they didn't want to make it go down too low and cause swelling the other direction. Okay. Make sure you're taking that drip with you. Even if it's not even currently running, but they were already on it, patient's already been charged for it. Okay, take it with you, restart it if you need to. That obviously was what was working for the patient. Okay, doesn't necessarily mean that just because they were on drip and you guys carry labetalol and you don't take the drip with you, now your patient becomes hypertensive and all you guys labetalol, but it didn't work. That's the reason they were on the Cardine in the first place. Okay. So if they were already on a drip and it was paused, whatever, take it with you. Make sure you're getting a copy of these with you in your transfer packet so that you have the protocols for you to do that, because that's all this is laid out in there. Labetalol, Cardine, and hydrolysine, I think, maybe. Again, order sets. This is just a little bit more about it. Please make sure you're getting all the information that you need for these patients to transport them and the parameters that you need to do that. This order set was more so when we used the Altaplace for when they had a drip and, you know, knowing if you had to reset pumps or whatever, knowing what the drip rate was, but not really use it much anymore because nobody else is using Altaplace. Our other facilities, affiliated things, you know, we work with American Heart Association, American Stroke Association, the Arkansas Department of Health, obviously through UAMS, and specifically with the EMS for nursing as well as the EMS side of it. This is a little touch on kind of what Robin was saying. It's real hard to see this. This one is from 2014 to 2016. There is a newer one. I just haven't updated the slide. The darkest areas, obviously, you can see that Arkansas is pretty dang dark. That is, the areas for county, it's actually broken up into county of the date range for the adults ages 35 and up that have had, having strokes is broken down by county. Again, there's a newer one out there. You can pull this off of the CDC if you want to actually look at it. Additional EMS resources, if you want any more EMS education on strokes or other things, you can go to any of those links. And do you have the app?
Not yet.
Not yet, for which one?
Pulsar.
Pulsar. All right, so I'm not a Pulsar representative, but I will say, put my little 2 cents on it. It is amazing. All right, you get a lot of information from it. She's probably rolling her eyes because it does. It's almost like double charting. However, on a data part of it, teaching part of it, and from the hospital side of things, it provides so much education and information to for us to be able to get, I say education, but I mean information for us to be able to do the education. Okay. It is a little bit of double charting. I understand that, but it provides so much stuff in there. You can change it from just general. You can put it in there as a trauma patient. You can put it in there if it's a STEMI patient. You can put it in there if it's a sepsis patient. You can change it to an OB patient. You can change it to a stroke patient. And it'll open up different parameters for you. But the ultimate thing is this can be given every step of the way for the patient, right? It's continuity of care for the patient. So when you open a Pulsara because you're on the scene, you put that information in there, you send it to the facility that you're transporting to, makes bells and whistles go off on their end, right? And then, so they know that's your code stroke activation, even if you didn't get time to pull up the phone, but the Pulsara went off. That's technically your code stroke notification. All right. That data that you put in there is already in the hospital. So now when we transfer the patient, you guys are here for the transfer, you get to do what? Pull up the Pulsara. That information that the hospital did is in Pulsara. The stuff that you did or that the other truck or other service did that you don't have data to, right, is in Pulsara. Now, when you transport it to that new facility, you designate to that facility, hey, we're coming to you, we have an ETA of whatever, all of that patient's information is going to that new facility. It's a continuity of care. It always constantly continues. The stroke, it follows by that stroke band number. That's why that stroke band is so important. Okay. Even if you don't use Pulsara, using that stroke band is still just as important on your inner facility and your seat.
So what is the app actually? There it is. Okay. Hold on. I was looking for the state one.
Oh, the state one,
It's Arkansas EMS.
yes. And the state one I will tell you, I will warn you, I had it for a little while. I got rid of it. And the reason why I got rid of the state one is because it takes up a lot of storage on your phone. So if you don't have like a big cloud thing or whatever, it will use up a lot of storage on your phone. The Pulsara doesn't, but the Arkansas Department of Health one, because all it is a whole bunch of PDFs that it downloads into your files for you. Okay, so that you can pull up their PDFs, and so it takes up a lot of data, not data, but room storage on your device. It is helpful. It does give you, you can click on that app, open it for you, and the Department of Health updates it. So every time you have a stroke ready hospital, so you are, I don't know, working at a new facility, you're doing, I don't know, work over somewhere else where you don't normally go. You're not as familiar with the facilities around here. It's helpful because then you can pull it up and be like, oh, well, I know this facility over here is a stroke ready hospital. I can take it there. So it is helpful. It does have stuff in there, but I am a pretty good big advocate about the Pulsara because of how it works. All right, so your homework. Your guys' homework is to teach BFAST to at least 2 family members or friends. They have to be outside of the medical field. Then it's kind of pointless, right? And then I have a stack of magnets under. It says give out at least 2 magnets. I like to play a game with EMS because we're all about shenanigans, right? So take the magnets, take the whole stack, put a certain number on each truck. And every time you go into a house, see if you can slap a magnet on somebody's refrigerator without them noticing you. Okay.
Oh,
That is community education. It gets it out there. Somebody's gonna see that magnet and be like, where'd this come from? But they're gonna stop and read it. Okay. So Put them on your trucks, play a game with the shift, see how many can get out there without being noticed. Please only stick them on the refrigerators. Don't go and put them on people's cars. Don't go and slap them around, you know, randoms or whatever. I did have a EMS guy, he got my number after this off my card and he sent me a picture and he slapped one on the drink machine at McDonald's. So, I mean, it's getting out there, but it does have UAMS on there, so please be mindful. Only put it on patients' houses, or not their houses, on their refrigerator in their houses, okay? Get the public information out there. If you want another extra hour of CE, you guys are getting 2 for sitting in this class. If you want one more additional hour, you can go to this link on the page. The guy that I took over for is still him on there talking, but he rambles a little bit more about some strokes for about another hour, and you'll get 1 more hour of CU. So it'll give you your 3 that you need for your recertification. Okay, any questions? That is my contact information if you need it, or you can get with Robin. She can get to you as well. I have some business cards if you need them. Other than that, that is the end of this class. You guys are done. Any questions?
Thank you.
Thanks for coming.
No problem.
See you again next year.
Maybe. We'll see. Maybe.
There you go, Mr. O. So sorry.
I gotta be.
I went to one side.
Yeah. Yeah. No. All right, so there's some goodies up here also. There's some shears, pins, carabiners, but please take the magnets, you guys, and get them out there for your.
I'm taking half of these.
Yeah.
It's been a while since I did one.